Good morning, everyone. It's a real honor and privilege to have this opportunity to address you this morning, and I want to thank the organizers for creating this opportunity. So I'm going to talk about 90-90-90, and is it enough to end AIDS in sub-Saharan Africa? And I'm going to borrow these next two slides from Slim, who uses this analogy of climbing Mount Everest in terms of contextualizing the context, the issue of epidemic control and so on. So one of the things he looks at is if you're climbing Mount Everest, the goal being reaching the summit as ending AIDS. But in order to get to the summit, you have to first get to base camp, and there are many ways of doing that. And one of the approaches since the adoption of ending AIDS as a public health threat by the UN declaration by 2030 is the UNAIDS articulation of 90-90-90 as a pathway to get to base camp, not in terms of reaching the summit. So why did UNAIDS, I'm having a bit of an issue with all of, why did UNAIDS choose 90-90-90? So there's three lines of evidence that was used. The first is modeling data from Ruben Greenwich, using data from KwaZulu-Natal, showing dramatic reductions in HIV incidence rates with test and treat. Then came the HPTN 052, which gave us unequivocal evidence that test and treat is important for reduction of new infections, and that even after 7 years of follow-up, that effect is sustained. And then we had implementation data just north of Durban in the district of Shlabisa, work done by the Africa Center that shows with increasing ART coverage, we see reductions in new infection in addition to the survival benefits that we see from this dramatic increase in life expectancy. But I think there are differences of opinion in terms of how do we know that we've reached base camp, and what are the indicators that we can use to say we have been successful. There was a meeting in the last quarter of last year in Glion where several indicators were presented, and none of these indicators are mutually exclusive. But what's common in each of these indicators is that you need reliable and robust measures of incidence rates. And I think regardless of whether you look at 90% reduction in new infections, comparing that to the 2010 data, whether you're looking at incidence rates of less than 1 per 1,000 or 10,000 or 100,000, or whether you look at new cases versus all-cause deaths in people living with HIV, or whether you look at the incidence prevalence ratio, they all are ways that people are using as indicators to determine if we're in the right path and if we know we've reached epidemic control. And I think there's sort of a general consensus emerging about the use of the incidence prevalence ratio. So if we turn to countries in sub-Saharan Africa, and we look at what data is coming out from the population level, and we look first at data from Botswana, and we all know Botswana as one of those countries in Africa that has been exemplary in their response to the epidemic. And they've, as published in this paper in Lancet, have reached or very close to the 90-90-90. But what was concerning when you look at the Botswana data is that having reached 90-90-90, the incidence rate is still 3.2%. And as people have investigated why, we found exclusion of particular key populations in measuring and monitoring 90-90-90 is one of the factors, or several factors, contributing to why having reached 99. So it's who you count, where you count, that's impacting whether we're seeing the outcome we desire, which is the reduction in incidence rates. So we have the big trial, again, in the Shlabisa district, the ANRA study, where we see that with repeat interventions in the community, the HIV testing rates going up, but the linkage to care very poor, and overall little impact on reducing incidence rate in the intervention compared to control. And then more recently, a few weeks ago, for those who were in Amsterdam, we've seen from the search data where you have health fairs every 6 months, and again, no impact in 3-year cumulative incidence in either the control or if you look at the intervention compared to the control arm. And the reason here was that very soon, in fact, in the first year since the search intervention started to be implemented, Kenya adopted the test and treat. So in fact, there wasn't really a control, but a control that was delivering standard of care at very high levels. And even though people's awareness of HIV status was high, it was as high in the control arm. And what we found was improved health-seeking behaviors and the implementation of the guidelines all impacting the outcome in the search study, and again highlighting where new infections are coming from outside the community, acute infection outbreaks, and small subsets of unsuppressed individuals. So overall, what we're seeing is that while we may reach 90, it's how and where we measure this, who is included, who is excluded, and I think generally what we are seeing in using the 90 targets is while the scientific rationale is sound, at a practical level, there are many implementation challenges, and that we still have the pop art study in the field to give us some indication of impact at the population level of incidence rates. And now, what are some of the obstacles that we continue to see in sub-Saharan Africa? And a big one is the age-sex difference in terms of HIV infection, where young women acquire infection 5 to 7 years earlier than men. But the cycle of transmission data that was that's published in Lancet 2016 and shared at the IAS conference in this venue in 2016 also flags for us what is driving these high incidence rates in young women is this men 25 to 40 who have relationships with young women under 25 and women over 25. And what's notable here is only 1 out of 5 of these men know their HIV status, and their viral loads are incredibly high. And so they're not really using our health facilities. So while we can celebrate the fact that we have one of the largest treatment programs and we have over 60% of people on treatment, we're missing out important groups. Very similar with young women under 25, 1 in 4 infections, 1 in 4 individuals know the HIV status. So 2 important groups, young women under 25, men 25 to 40, are not really using health services. A lot of them don't know the HIV status. And if you look at women 25 to 40, we do slightly better in that 40% know the HIV status. So I think when we count in health facilities and we compare to what we're seeing at a population level, at a community level, we're seeing big disconnects between who's utilizing services, who we're counting, who we're reaching, who we're getting linked to services, and who is virally suppressed. So in summary, that the end of AIDS is an aspirational vision, and that's the summit. Epidemic control is the current milestone to reach that, and 90 is the chosen path for now until we identify better ones. that the incidence rates and IPR used to indicate whether the chosen path is correct and going to epidemic control. We need to continue to get better data on that. And a big obstacle in sub-Saharan Africa is the high incidence rates in young women and the importance of men 25 to 40 contributing to that. And that I think what's clear is that treatment alone is not going to give us epidemic control. But I also want to just say that we tend to, in our presentations, whether it's to government officials or to the public, oversell the good news story. And in fact, this overselling of the good news story is coming back to haunt us, in that people who make important decisions are viewing these good news stories as we've turned the tide on the epidemic, and we don't need to invest further in HIV/AIDS, and we can move on to other issues. And the reality is that we have nearly 38 million people living with HIV. We still need to put about 40% of those on treatment. Most of that is in sub-Saharan Africa. We're still seeing something like 960,000 people dying of AIDS and 1.8 million new infections. And the 1.8 million new infections has remained static, and preventing new infection remains a challenge. And so while we've transformed AIDS to a chronic manageable condition, we are not winning the battle on prevention. And finally, just to say, to end AIDS, we will need a vaccine, we'll need a cure, but until then, we need to do our very best with what we have available to prevent and control the further spread of HIV. Thank you very much.
I would like, first of all, to thank the symposium organizer for giving me the opportunity to give this talk today. And actually, Professor Quarraisha Abdool-Karim made my life a bit easier because I can cut half of my slide. So the roadmap, actually, I'm going to focus on mostly on those challenges that Quarraisha just mentioned, and some kind of evidence-based approach we're trying to work on to try to solve them, at least to have the FED90 achieved. As you can see, we're not yet controlling the epidemic, and the incidence still really staggering. In any case, this is the 90-90-90. Concentrating on the FED90 is basically to say we have about 73% virologically suppressed from the baseline. And coming from Amsterdam, actually, this is a UNAIDS data which they try to actualize regularly. You can see that all the places are not equals. There is some good model and worse model. And East Africa and Southern Africa are doing good, are doing well, but West Africa and Central Africa are performing badly, regardless of which 90 you look at. So this is really worrisome. Why things are going so badly in West and Central Africa? We can discuss that later. You just heard about Botswana, and with the caveat that Professor Abdool-Karim just mentioned, excluding the key population in the accounting. So it's no-brainer, actually, that at individual level, a population level, you make a difference by trying to get people engaged, virologically suppressed. They're gonna live longer, but also you're going to stop sexual transmission, and for the community, that will be good. So those are benefits, but I would like to stress out that engagement in care is not, it's a dynamic process. There is people who from the start are well engaged until they finish. Those who start well, they finish bad. Those who kind of up and down. So it's really a dynamic process. And when you look also at virological suppression, this is a CDC data from Gary Marks showing that looking at the last recent viral load, he gave an optimistic picture of virological suppression. But looking over a longer period, only about 60% of people can, you can claim that they are virologically suppressed all the time. So this is really an ongoing battle, which can be a challenge in some setting of the population, mostly young age, adolescent, male gender is an issue in sub-Saharan Africa. Issue about stigma is still playing a lot of role, especially also in West and Central Africa. You may wonder why pregnant women, despite the motivation of having a baby, they're less adherent and less engaged, and postpartum is a big issue. Issue about structural issue in Africa, it's a big problem. Mental illness, we don't talk much about it, but depression, postpartum depression in all professional, it's a big issue we don't talk much about. Substance abuse and unmet need. So this is our data, our own data from Southern Africa. We show in adolescent, the time to virological rebound is really very short compared to adult. And this, when you stratify, even we have a dose response by age. And also, postpartum, it's a big problem in pregnant women. This is meta-analysis, about 51 study, 20,000 pregnant women, only about 70% had adequate adherence. But if you look at postpartum, that adherence level even go very lower. And again, speaking or really issue possibly of many competing need in pregnant postpartum period, but also issue of postpartum depression. In option B plus era in Malawi, we have recent data showing that loss to care, retention in care, it's a huge challenge, and this increased as time passed. We just hear about the key population. We're not doing a good job reaching out the key population. We just talk about adolescents, but men who have sex with men, people who use drugs, young women, and other key population. So this is data from Brazil. You can see that in terms of virological suppression, it's really far for excellent. So we tried to come up with some colleagues internationally, some guidance some time ago. We published in the Annals in terms of adherence in retention in care guideline. This was about 2012. We recently tried to update them based on the recent evidence on some really innovative approach to try to make a difference. You see the universal testing home-based care in INRS 12249. The issue about a community-based approach of initiation antiretroviral in the SET trial in Uganda and Kenya, which think may make also a difference. Rapid initiation of antiretroviral. We used to wait about 2, 3, 4 weeks with preparation before we get people on heart. Now WHO is recommending within 7 days to get starting on antiretroviral therapy. Cash transfer, it's kind of a model which has been tested and seems to have some promise. Peer support in mothers, mother-to-mother program, differentiate service delivery model, which I will show you soon, and also implementation of mobile health technology. I'm going to pass this Professor Karim show, the INRS data, the search data, but what I would like to show you is this initiation of antiretroviral within relatively few days. This is the model in San Francisco, but we have more robust data, a randomized trial from South Africa, from Uganda, and from Haiti, that initiating antiretroviral therapy within a few days make a difference in terms of virological suppression. And this has been now recommending by WHO, excluding that you exclude possibility of TB iris in terms of CNS iris. Cash transfer, this has been tested in DR Congo, and as you can see here, small incentive, reasonable incentive kept mom in care. both pre and postpartum. And P2P model in Nigeria, Zimbabwe, also made a difference in terms of retaining mom in care postpartum. So I think those are relatively scalable model, which I think we need to start to look at to make a difference. And you're hearing a lot about differentiated service delivery model, which has been pioneered by Wafa El Sada. And I think we have evidence now, even here in South Africa, in Cape Town, those community club model of antiretroviral, patients who are clinically stable don't need to go every month or every 3 months at the clinic. They can stay in the community. They have those adherence clubs where there is some peer-to-peer motivation, collection of antiretroviral, and counseling. And it's shown that about 70% risk reduction in terms of being retained in care. And in a meta-analysis, we show that they at least at equal as clinic-based model in terms of virological suppression and more likely to be cost-effective. In terms of adolescents, also we have those club models are being piloted, and the recent data published are promising to show that we may make a difference in those key populations as adolescents. And I will just finish by mobile health technology. We live in a very digital world now, and this is very simple. Everyone in this room and our grandma in village have a cell phone. The first trial published in the Lancet showing that it has an impact on adherence virological suppression was in Kenya. And the colleague, we did the meta-analysis. We confirmed that this definitely it's not the issue of reminding someone take their medicine on a weekly basis. It's the issue of that someone is checking on you and care for you, can support you, and whenever you have a problem, you can call back. It's that support feeling that we show that make a difference. Someone there care, and that really make a difference, and we have data to show that. We're busy conducting randomized control trial in PMTCT to see whether mHealth also make a difference. The previous data showing was in general population. So I will stop there and just say, I think in terms of the FED90, there is a promising intervention to try to make a difference. Whether 90 going to control the epidemic, I think it's been said we still need to do more. But this is, there is some indication there that we have intervention that can make a difference. And just want to finish here by acknowledging my collaborator, my fan supporter, and some few colleagues who share my slide with me. Thank you very much.
Thank you very much, Mr. Chairman. Do I have data? I don't. I'm data starved. So you're not going to hear one word of data from me because it relates to PMTCT. And I'm only going to give you one fact. When we started the PMTCT programs here, the transmission rate was about 32%. Joburg was about 35%. Now it's less than 2%. If that isn't success, I don't know what it is. What we haven't really succeeded much on, because most people have ignored the problem of women, is that breastfeeding transmission has been a major concern for us, because it's very easy to say stop breastfeeding, but you stop breastfeeding, you get a malnourished child who quickly dies. So have we solved that problem? Only partly, but not completely. So that's one remaining part of the studies we need to do. However, I'm not going to speak about all of that. I want to speak about my own experiences, and that has to do with the idea of community engagement interpreted very, very widely. In South Africa, you can't have community engagement without having political engagement. The two things go hand in hand, and you cannot go into a community and try to organize them, as we did all over this country, without tackling the difficult, dangerous, and very, very prolonged struggles for freedom from apartheid, etc. So that's what I take as community engagement. I'm going to give you a set of slides which will show you how we develop. And it's not my slides particularly. Slim knows about it, Quarraisha knows about it, and I'm sure people in the audience know about it. But what our experience was, first of all, is to get a vision of health care. What did we want after apartheid? And is this thing working? Okay. This is a very quick summary of the sustainable development goals to which we would subscribe. I'm not going to go through all of them because there are quite a few, but you see it includes everything which is important, like climate change, which has been discarded by some people in the world, but things like poverty and clean water and sand, the usual components of what we call development. What is development? Development is the liberation from poverty, from ignorance, and from national recognition. That's what poverty is. Amartya Sen, who is a Nobel laureate in economics, defined it very well, and I go by that definition. So all of these items on the SDGs are part and parcel of development. The next slide simply tells you one thing. In all our struggles here for the past more than 50 years, and I wasn't around when it started, but there were very good people who were, from about the Second World War to now, there's been a struggle for equity, that means fairness, in health care. We don't have a fair, in fact, we've got a hopelessly unfair health system. So the fair health system we thought about was what's written there, and that's the national health system. It's not too dissimilar, it's not like an innovation. It's there in the UK from about 1945 or so. It's been in Scandinavia, it's in Thailand, and it's successful in many countries. It's particularly important here as a goal because very few countries in the world have such a gap between rich and poor. And inequities inherent in that are really harmful to personal life, to national life, to community life, and to the country as a whole. So national health insurance is a foundation of what we have believed in for many, many years. There's been a lot of much dispute. I mean, every other person who's never experienced national health systems objects. Why? Because it's personally harmful for their profits. Our health system is hugely materialistic, and the people we train are even getting more material. So there's a lot of opposition. I don't want to pretend that we don't have a fight ahead to, in fact, introduce it. And my colleague, the Minister of Health, I think he tears his hair out when he gets the comments from the committee. So what did we think, what were the components of this national health system which were important for us? And there's a WHO report. Most of you will know about that. The things that undermine national health, fairness, and equity are hospital care. Hospital care. Sounds funny, but it's true. It's fragmentation of health services, and it's uncontrolled central determination of the health system. Now, the hospitals is a paradox. Of course, we need hospitals. I'm not trying to tell you that we don't need hospitals, but a system which is based on hospital care and ignores primary health care and the intermediate care and community care, it cannot be a fair system. So that was our belief then and now. The next one is we set out, and this is a diagram we used. I belong to an outfit called the Planning Commission. And the Planning Commission, surprisingly, was introduced by a president who wasn't very successful in much else. But we did it then, and this is what we got. This is what we, and I believe in it, I think it's right. And you'll see that the Planning Commission at the top is social determinants. It's not hospitals, and not transplants, and it's not expensive drugs. It's social determinants, housing, sanitation, water, freedom from oppression, lack of criminality, etc., etc. That's what social determinants are, and we put it right at the top. At the bottom, I won't go through the rest. National health insurance is part of it, but at the bottom is optimum management and provision of the major causes of morbidity and mortality, about which I have spent my life because I worked in a hospital, and the research I did was for that. The next slide is really a weirdo. In the Planning Commission, we thought about what we should be doing. It's not sufficient to say plan for equity. So this is what we drew up, and I hope it works, but it's to say we must tackle poverty and inequity through the following means. So I can barely read it myself, it's swinging around so fast. But you get the picture. Once you look there, you'll see that there are things which are familiar to you. It'll be, I can't even read that now. But whatever it is, you can read it. And you'll see there are all these components of healthcare, which are essential. It's not different from the SDGs. For heaven's sake, it's not like a discovery. I mean, it took us 5 years to come to this, but we all know these are the things. Don't you know about sanitation and housing and employment? So this is all that. I'm not going to go through the whole lot, but anyway, I'll go through it very quickly. It's what we drew up then. It may not be data, it might substitute for that, but this is what we aim for prosperity and equity. We have the most, as I indicated, unequal society by the Gini coefficient. So for those people who are obsessed by data, go look at the Gini coefficient. It's a measure of that gap between rich and poor. And we need to fight for equity again. How will we get it? And this is where community engagement was central to my experience, central to the experience of many of my colleagues here in this fight for not only freedom, for the new society. And you can see we need a strong leadership, but we also need strong citizenship. You've got to work with the people. You need to have an effective government. You need all three components. And the part we worked in was all three, which didn't exclude citizens, mostly poor people, but not only poor people. And you'll see that what this paradigm did includes that in what Amartya Sen called capability. What do you have? What do you have to earn a living, to help society, to relieve suffering, etc.? You need what he called capabilities. And that's at the bottom blue. Capability is what you've got. And you don't get that from heaven. I mean, you probably do. But you don't get it just like you get it from education and housing and family care and so on and so. That's capabilities. You need the opportunities like education and opportunities for participation in government. And then you need conditions, which I told you about, sanitation and housing, etc. And the next part is the remainder of that circle. And it tells you furthermore what we need, and it includes things like the environment and so on. So that's the complete circle we worked out. And I'm sure you'll say this didn't take a genius to work that out. We knew a lot of that. But anyway, it took 5 years of a group of very, I wanted to say talented, but you'll have to excuse me from that crowd, but very well-equipped individuals who knew about toilets and knew about mining and knew about manufacturing, who knew about sending, etc. So that is the group of people that came to that. And I know some of you may laugh that it takes so many people to come to so obvious a conclusion. The next slide is what we think about equity. We don't just grow rich. Most of you come from countries which might well be rich, but you are not equitable. You've got a path, you see that the path you choose might often go up to that, but it won't be fair. So we need something in between. And you'll see what we call today. We want to go in the middle. That was 1994 when we drew it up. We don't want to be right on top and say we've got a GDP of X, Y, and Z, and we've got that tremendous figure they throw. 1% of our population owes 95. All that sort of stuff. That's not what we're doing. That's not what we're fighting for. We're not fighting for the rich to get extremely rich. We're fighting for fairness so that the poor get well off and so on. And the need for equity and inclusion, forget the writing, but it's part of our social contract. Those of those of you who've been familiar with that term, you know it comes from the French Revolution, and it was Jean, I just forget his name, but anyway, it was his that citizens contribute to the state contributes to the citizen. That's the compact. We must do our job, and the state must do its job. And very often, of course, the state doesn't do its job, and people are reckless with what they need to do. I think this is my last slide. And basically, what I did learn from the Planning Commission is we don't need just jobs. We don't need, this horrendous salaries the CEOs get. God forbid, like 30 million, 100 million, where do they come from? I read a chap called, what's his name, Markham, I think, Thinking Fast and Slow. I don't know if you read him, he's an economic Nobel laureate. He says if you really, he does experimental work for an economist, unusual. But he says if you he took the best CEOs, and they told him, all right, you work with these guys. He worked with them, and at the most, they improved the company's profits by 20, 30%, not 100%. That's the best CEO. So can you imagine the rest of the crowd who are holidaying in Bermuda and traveling around in Rolls Royces and have private planes? You think they're doing us that much of good? They're not. And I apologize to any CEOs there. I have nothing against you personally. You're just part of the national and global problem, and you need to sort out. So don't take it out on me. Okay, that's all I had to say, really. That was my community engagement. I thought it was appropriate. I tell you how we have come to the point where we are now. We've had to struggle for this, but it's an idea. If Mandela was alive, he would say, I will live for it, and if necessary, I'll die for it. Thank you.
Thank you very much to all our presenters for these brilliant speeches. And due to the time constraints, we will only open one round of questions, just very quick questions. 3 questions, please. The ones that want to ask anything can go there and do it. Thank you.
Thank you. I'm Winnie Cele from UKZN, South Africa. Thank you to the panel that was just presenting. My question to Jean, Nachega, and Abdool-Karim is, does 1990 focus on the aspect of mental health problems to prevent any other mental health problems that the person might develop after having been diagnosed with HIV? And if yes, how does that actually address that particular aspect of mental health? And again to Karim, we said, you well said that we want 90-90-90. Is it enough to end AIDS? Mental health problems, they do develop, or else people, they do develop AIDS due to mental health problems that were not attended to or poorly treated. What do you do to actually attend to those using this 90-90? Thank you.
I was going to say to Quarraisha, there are unintended consequences of trying to climb Mount Kilimanjaro, where there's base camp, where there's litter and all sorts of things. Now, for me, the litter is the many orphans, which it doesn't look like there's any kind of investment or commitment to make sure the mental issues she was talking about are addressed, because then all those gains are going to be lost if that is not attended to.
To the panel in general, we are talking about an uncontrollable virus. I want to introduce a virus in our discussion. Why is it that we never mention the Cuba model in the containment, control, and management of HIV? Cuba is the only country in one of the most endemic areas that introduced a radical methodology to the control and treatment and overall management of HIV, and they now stand on last count at less than 5% national infectivity. And yet, wherever we go, I've never heard any mention of the data from Cuba. Is Cuba method a virus that we don't want to deal with? I want to know.
So I want to answer the last question. It's the easiest of the lot. That why don't we learn from countries which have made a success? And Cuba has made enormous success in the face of huge sanctions from the US. And it has done that by any criterion you want to look at. The problem is a political one. I think in this country at least, and many countries like this, when our profession, our medical and nursing profession, hear about Cuba, their hackles rise. It's like you're asking them to become slaves of society. They have no understanding of what Cuba has been through. So we as a country had a lot to do with Cuba. When Mandela was first released, he went first to Cuba. When they asked him in the States, hey, what's wrong with you? You know, we helped you and you're now going to Castro. He says, yes, but Castro was there when I really needed him. And so there's a strong feeling for Cuba, but that doesn't mean we are passionate without being thoughtful. There are many things about the Cuban system which apply well in Cuba, are difficult to apply in our circumstances, but there's no denying that the social organization of Cuba resulted in the control of the HIV epidemic and hasn't got sufficient recognition as many of the drugs and mechanical interventions we have. That's a reason, and you mustn't believe that all of us fall for this line about Cuba, we don't. But it's a problem when you're trying to convince a group of people who are absolutely immersed in materialism.
Thanks. So I had a few questions on 90-90-90 and the caveats and what's missing, etc. And I want to start by saying that I did not devise 90-90-90. And 90-90-90 stands for 90% of those living with HIV know their status, and 90% of that 90% is linked to care, and 90% of that 90% is virally suppressed. So when you do the maths there, you get to viral suppression in about 72 to 73% of the people. So these are measurements that we're using in terms of the population of infected individuals, their linkage to care, etc. And it's also premised on the fact that if you're virally suppressed, then you are very unlikely to transmit the virus, and that also translates to U equals U, undetectable equals uninfectious. So all the points that are made about the importance of mental health, the importance of who we include and who we exclude, and whether we have a uniform application or implementation, I think we have to recognize that within Africa, we have a diversity of epidemics within and between countries, and that when we look at data at a country level, we may be masking things at a local level. When we look at the 90s, we're missing things like who is included, who is excluded. We're also missing factors that influence who seek health services and who don't. And we also miss the challenges and the granularity of achieving 90-90-90. So I'm pleased that the two issues of mental health and often vulnerable children come in. And, you know, we hear repeatedly one of our biggest successes is the close to elimination of transmission from infected mothers to infants. But that was, that's a story and interventions that we started in the early 2000s. We ignore the fact that many parents of these children did not survive to benefit from antiretroviral treatment. So we have large child-headed households, but also time is moving on. And there's a whole generation now of adolescents who we protected, who we saved from getting infected or giving access to ARVs, who are now entering adolescence. So we're also seeing a convergence of vertical and horizontal transmission. And the question we need to be asking ourselves as we do 90-90-90, bearing in mind that it's just the base camp to getting to the summit, is what else can we be doing, what else should we be doing, and that are we going to reverse the gains that we've accomplished by reductions in investments, for example. So that combination of horizontal vertical transmission plus the fact that we have reached just over 60% of the people who need to be on treatment, we still have a way to go. And that's going to need huge human resource capacity, it's going to need huge infrastructure investments, and it's going to need huge financial investments. And both ways, those are important gains. And if we take our foot off the accelerator at this stage, we're going to reverse those gains and also make the challenge of reaching the epidemic control even greater through this sort of more complacent approach that may emerge by 90-90-90. Thank you.
Yeah, donc I will just be brief and try to complement what Quarraisha just mentioned. So mental health, it's really an emerging issue, which we use in the early age of the epidemic. It was neglected. I think in the recent year, there's been a huge increased awareness that this is an ongoing problem, and whether clinician, public health practitioner are now sensitized to try to screen for it in programs or in clinical setting. We have a very easy tool, the Mini or other kind of tool that you can use to screen and try to engage the patient in treatment. Just in the context of just we had with Eric Gooseby or what we had this morning about the aid supplement of chronic disease. So, and the SEARCH trial actually in Kenya and Uganda, rural Kenya and Uganda, the intervention was a community multi-chronic model intervention. It's not just HIV, but also mental health, hypertension, diabetes, try to screen for those diseases. I think this is increasingly becoming important that HIV should be seen as now a chronic disease, other important chronic disease, and we need to really try to screen for them, including mental health. And as again, I want to reemphasize, this is something it can be integrated and we can make a difference, because the impact in terms of adherence in those key populations, whether it's adolescent, they suffer of depression, unnoticed depression, pregnant women, postpartum depression. It's been, I'm not sure if there is psychiatrists here or OBGYN, but about 30% of postpartum women are depressed, and this impacts adherence. And this is the moment where they should not relax because they are breastfeeding, so the likelihood of transmitting the virus is increasing. So again, this is depression. We need to start to talk about it, not only for our patient, but also for ourselves and the staff and everyone, as we just again be aware recently of the loss of one of our colleagues.
So at this stage, we are going to close our session, thanking again our presenters and thanking again for your audience and the contributions that you did to enrich our discussion. Thank you.